Active recording. All right. Plan of attack is phone. In here, in lecture, the next unit is the completion of this immunology unit, which is rather detailed at the end. So I'm going to try to minimize the carnage. I mean, nothing is more complex when you start getting into B and T cell activation and cofactors and co-stimulation and interleukins. But we're going to cover some of it. I'm going to certainly tell you which ones you have to know. It's a hard unit. That you typically, I do the physiology of like circulation with that unit as an exam. That will leave for the final exam typically, and I'll see if I tweak it or not, respiratory, digestive, urinary, and repro for the final. In the lab, and I may change this around a little bit. I may just put respiratory with it, or I may do the other one. Maybe I'll do the respiratory in the lab. But in lab, we're going to do the cardiac unit. We're going to start with EKGs today. And similar to what we talked about, if you remember, we're back when Dr. Buxton was in. We'll get some volunteers or else willing or unwilling volunteers. And then we have, and maybe I'll do the respiratory with that too, because I have a respiratory lab that goes with it. Okay. That's kind of where we're going. Oh, everybody, we've got a minion. In Hebrew, a minion is a quorum. Everybody is here and ready to participate. If you didn't know, just a little help with that. Passover's coming. You missed Purim, but Passover's coming. 10 Commandments, that, angel of death, plagues, Egypt, Old Testament stuff. I promise not to do too much shtick when Dr. Badger is here. Warn your buddy back there. She gives me a hard time. This hurts. I have missed you. Even Jenna. Don't wake her up. I better delete that part of the recording. Okay, enough fooling around, Lou. They're going to give you bad reviews. Moving on. Okay, this is where we kind of left it. Different kind of immunoglobulins. There's 5 categories, and this is me reading the PowerPoint type stuff. I give you my spin on it. Okay, you're familiar with the structure, the height, and we covered a little bit. This is just a quick review. The heavy and light chains, 2, they're held in the middle. Okay, the variable regions are important. That whole letter Y thing that's coming up. So the constant area or the stem of that T or Y really determines what category it's in. Okay, and what things it can do, like detailing here. And then this, of course, is sort of the general representation, but this is the key. These are the areas, the so-called variable areas, are designed to be specific, to adhere to, attach to, interact with what we call the determinant. The other word is epitope, E-P-I-T-O-P-E. And you'll see both of them depending on the sources you read. And here's their sort of model schematic. These are the categories. I remind you, I use MAGE, IgM, and again, this is how we track when we can, because we can basically do similar to what you do in the lab. And I don't know how it is done today in the hospital. It's probably more modern, but in our day, they would use electrophoresis and basically be able to determine the different what antibodies were there and what proportion. So IgM was first on the scene, then IgG. And so that's where you could determine those levels to see whether it's an acute infection, whether it's a recovering infection or a infection that's being now your immune system is responding to. And if you monitored those levels, if all of a sudden IgM went back up, you got a problem. It's not, in other words, your immune system is not getting the job done. So whether they do that today, I don't know, but this is just giving some context. So this one, the IgM is the large one, a pentamer, which makes it really great for agglutinating, kind of like we saw with those blood tests that we did with a little, with the speckling pattern. Complement, which is part of it as well. Okay. You can find it, as you can see, typically in different ways in secretions, but by and large, this is IgA rather, a monomer, and that's in all of your secretions. That's your principal defense from an antibody perspective. We have other stuff that you saw when we talked about the innate immunity. You have basically a variety of enzymes, lysozyme that destroys gram positives, and a variety of antimicrobial factors in body fluids along moist linings and entry points. Here's really the schematics that you can look at and read through that. Here are the other ones. D, we really don't know. We think it's prominent with regard to B cells and basically helping to enable B cells, which we're going to see. We'll probably touch on today without getting into a lot of depth. Maybe we'll get into some depth with it. IgG, which is by far and away the most abundant. None of the others are close. 75 to 85% in the plasma. That's what we typically, when you're looking at when you're looking at the globulin fraction, which we often do, we look at relationships in blood of the ratio of albumin and globulin fractions. It's really significant. That's where we look for IgGs, typically either secondary or late primary responses. That's the one that imparts immunity from the mom, from the birth mom. That provides the passive kind of immunity, which means it doesn't linger for about 6 months. That's an important point. And the IgE, as many of you and I've had a number of inquiries, and they're all good, about topics that involve allergies or asthma or immunological phenomena. And this one plays a very important role. I don't want to go crazy about it, but the IgE is a big one. And to summarize, you're going to see a lot of these mast cells, which are principally basophils that have flipped once they get out of the bloodstream, and basically are the ones, depending on where they are, trigger typical allergic responses and sometimes very dangerous ones that are there. Principally being mediated through histamine. I can't read this. I promise. I told my wife I'm going to go get my eyes checked. So as you can see, they're antigen specific, but they can switch. Again, IgM early, IgG would be a classic example. Almost all secondary responses are IgE, and other switches can occur. So just the summary. So you'll have to know a little bit nugget about all of those. The classic ones that we see, the IgA is typically found more often as a dimer. The IgM is a pentamer, and everything else is pretty much a monomer. Voila. How do they work? 4 things you got to know. Okay. They're not destructive by nature. They're effectively tagging, immobilizing, detoxifying. So when they neutralize, a lot of these agents work through toxins. Most bacteria do their damage through toxins that they secrete. So they neutralize them. You saw with the blood test, a lot of times, if they have foreign, they latch onto them. That's agglutination. They bring them effectively out of solution so that the macrophages can come along and gobble them up. And the same is true for precipitation. And complement fixation is just something that enhances the process depending on their category. So that's how they work. And they give you a little nugget about each of these in the next slides. And that pretty much concludes this part of the presentation. And we get to the last PowerPoint, which is remember, this was all about antibodies and B cells and plasma cells. We're going to get into T cells. Oh boy. Neutralization, simplest. But again, we're effectively, what are you neutralizing? Toxins or things that potentially could be toxic. So if somebody comes in with what we call a tetanus-prone wound, they're really bad. Dog bite, gnarl, tough like that. Some kind of injury out in the field or something. Man versus lawnmower, that type of thing. Effectively, and we don't have a reliable history of their tetanus prophylaxis. We give them a tetanus shot to give them immunity, but that is insufficient because the tetanus will kill them if they get it before that immunization will take the 3+ weeks that it takes to work. We give them what's called tetanus. We basically the hypertet, which is a tetanus immune globulin. So it is the antitoxin to the way tetanus works, which is by way of a toxin. That's why that's so important. They block the sites on whether it's a virus or an exotoxin, prevent antigens from binding, the antigen on antibody complexes, then effectively undergo phagocytosis. Agglutination, bind to the same determinant on two different ones. So those arms, whether it's a monomer like IgG or certainly a pentamer, can latch on. So the complexes will become cross-linked, basically a lattice, and mismatched blood cells is a wonderful illustration of that. And then precipitation, basically, again, complexes takes them out of solution, and all of these enable or facilitate phagocytosis. Got it? Complement, main antibody defense against cellular antigens. Okay, when several antibodies are bound close together on the same antigen, complement binding sites in their stems align. And so what does that does? Amplifies the inflammatory response. That's where opsonization comes there. So there's certain ones that are in cells already and have not changed and are still being regarded by antibodies. It's a unique system in that, but it's just remembering the name complement and the fact that it's enhancing inflammation and plays a pivotal role in that opsonization, basically enabling phagocytes. Remember, to make tasty, do I have to go into my spoonful of sugar routine? Mary Poppins, remember her? I told you, my sister read me that when it came out, 1955. She still treats me like a little. That's the kid brother system. Okay, ideas. These are worms. So worms are too big for the regular attack. Okay. So IgE, that's why we see it, these are parasitic infections. Worms are just different kinds of parasites. So are protozoans like amoebic dysentery, giardiasis. And what happens, the way they destroy the worm is the IgE, okay, triggers the eosinophils to release all the chemicals in those red granules. They start to destroy the worm, and then it can be gobbled up. I'm not asking about that, but it's really interesting. And here's the other one. These are really important. Was anybody, if I don't, you don't have to disclose it, but okay, we'll do it in this context. My son was working for whatever construction company he was working for when COVID, and he got clobbered by it in 2021. So they got monoclonal. He went to a place for monoclonal antibodies over in West Mifflin. That was one of the early, very effective treatment. They had a monoclonal, meaning they had basically commercially prepared an antibody, okay, with and basically it's a tumor cell and a B cell that was designed to fight effectively the original COVID-19, okay, and by doing so, they were able to cause that B cell to generate large amounts of what they call monoclonal antibodies, specifically, and was very effective. At that time, as long as you tested COVID positive, if your insurance didn't pay, which his did not, the government would pay. It's like a $2,000 infusion they had done. So there was some of that. There was some controversy associated with those, but I'm giving it to you for context. So as we summarize, yeah, okay. Hold on. I'll get back to her later. So it's the boss. So to summarize, the antigen antibody complex, when you're looking at antigens and antibodies, it's not inherently destructive. That's where we're getting the T cells. They prepare them for destruction. They do not invade solid tissue unless there's something present. Okay. Antibodies can act intracellular if attached to a virus before it enters, and I'm not familiar with that mechanism. So that ends that little chat from that particular thing. And now we move on from there. Okay. This is the hard part. I'm not doing it to frighten you or anything like that. I'm just being very honest. This is to me, every time I go through this and look at other resources, I learn a little bit more. It is very complicated. T cells and how they work effectively. The whole ball game is this is for things that have either the cells are altered because they're cancerous, they're altered because they're foreign, they're altered because they've invaded, typically by a virus or bacteria. So think classic things like tuberculosis forms inside of the cell, alters its markers, now representing it as a foreign cell. HIV, with the potential to become AIDS, alters the single most important cell as it invades and really starts to take over that whole cell line known as the helper T cell. It's unimaginable how dangerous that is if it's not addressed. At least we know it can be treated. So cells that have been infected with viruses or bacteria, cancerous cells, abnormal cells, transplanted, transfused elements. Some T cells directly kill cells, others release chemicals that regulate the immune response. The helper T cells are the ones that release the chemicals. The ones that are the killers, okay, are known as cytotoxic T cells. More appropriately, vernacularly call them killer T cells. We understand this a lot more now than we used to. When HIV/AIDS first came out, we used to see now we know it's a little bit different. It has to do a lot with. I'm trying to summarize it. You don't have to worry about antibodies. After a certain amount of time, we stop producing them. Okay, so you typically, barring something unusual, something in your bone marrow like a cancer forcing stuff out, or a cell line forcing, a cancer cell line forcing itself out, not a problem. This is a system that once it's on, we have to shut it off. We talked about blood clotting. Once the clotting is done, all those blood vessels that are constantly being repaired, you got to have something to go in there and bust up the clots, or they're not going to be functional. This is where the helper T cell comes in. We have to have some way to shut off the system. When you hear about autoimmune diseases, a lot of times the shut-off switch, whether it's antibodies that are produced too many, whether it's antibodies that are foreign, depending on what category they are, whether they're antibodies that attack you instead of when they shouldn't, or whether they are parts of this line which is causing havoc in your immune system. And the last thing you want to do is cause havoc in your immune system. It's easy. You're looking at someone who had to take immunosuppressive drugs after taking an I told you. They started to treat my bladder cancer with immunotherapy to stimulate my immune system. It did such a good job stimulating it that it's not a big deal. It was unpredictable. You pay your money, it takes your chances in life. I wasn't angry about it, but it basically all of a sudden, if you were here when this started to happen about 10 years ago, I'm having to wear a brace on my hand. I couldn't move it. It's arthritic everywhere, flaring all over the place. And then I had to go on immunosuppressants. Hey. And you're all sitting there going, we heard this nuts before. But the reality is, it's a very difficult system to control. And I don't know about you, when we watch every other commercial is trying to sell you pharmaceutical agents. Have you noticed that if you watch any television? Every damn thing they want to tell you about, oh, you won't scratch. Your psoriasis will be wonderful. Do you know why? This is a preaching point. I was taking Humira. And I'm not blaming the university. They changed our health insurance. We have good health insurance, but they went to a high deductible plan. When I was on the Humira, my first 2 doses, are you ready? The first 2 times I ordered it, which is you order a month's supply at a time. After 2 months, I owed, are you ready? To the special pharmacy, $6,000. $3,000 for 2 shots. Hello? Not covered by insurance. That was the deductible part. That's why they spend a ton of advertising dollars, because the insurance company's paying them $10,000. You're only paying them $3,000 or $12,000. You're young. I don't mean to, but I have to acquaint. It's pharmaceutical companies aren't your friend. They are a business, and as a business, they have one job in life: make money for our stockholders, and continued employment for all the wonderful people who work there. They try to do good, but they got to make a profit. Got it? Good. T cells, more complex than B cells. They often see a therapist, both in classification and function. Could one of you, thank you, God bless. She likes me. Maybe it's because I didn't see the other ones of you smiling. Two populations of T cells are based on the glycoprotein receptor as they form from two different lines. One is the CD4. Those are going to become helper T cells frequently. The other is the CD8. You must know this. They are going to be the ones that are going to become the cytotoxic or killer T cells. That is important. Understand, once they have, and you'll see it, once they mature, we don't say they're ready to go. We use the term naive. So before they become helper T cells or killer cytotoxic T cells, until they encounter a bad guy, we call them naive, and we refer to them as CD4 for helpers, CD8 for cytotoxics. Once they encounter and start to get busy doing their thing, now they have become activated. And again, they're only going to respond to that. Once they're tuned in on one particular determinant, that's the only one they're ever going to make. So the CD4 cells usually become helper T cells that activate, and that's why they're the helper. That's the single most important cell. They activate B cells, they activate T cells, they activate macrophages, they direct the adaptive immune responses, they communicate with your inherent immune responses, not the adaptive ones, the ones that are always there. Basically saying if something got to the point where the helper T cells are activated, we have a problem with a boundary. We have a problem with the sentries that are out there. That's just the way it works. And mostly those helper T cells, and over time, to shut these off so they don't produce scads of what you're going to see are these powerful proteins we have collectively often called cytokines or pro-inflammatory agents. Don't go crazy, because that's what causes a lot of autoimmune diseases. So they become regulatory T cells. Years ago, when we first heard about AIDS, we refer to them as helper suppressor T cell. We call them suppressor because the helpers activated the system, the suppressors shut it down. And then we looked in the old days to diagnose AIDS. We look for an inversion in the helper suppressor cells. Now to diagnose AIDS, we are able to more technologically be able to ascertain the absolute numbers per microliter of these cells. And once they fall below a certain level, that means your immune system is collapsed. And now you have AIDS. And now you're going to die sooner than you should. So that's an important point. The CD8s become cytotoxic in the parlance, killer T cells, not appropriate. Okay. Also, those can become memory T cells. All of these are activated T cells. Again, the term is naive prior to that. That's immunological terminology. Depending on where you're going and tests you are taking, you can ask me and I'll give you what information if you can. There's there. Can't give you all of it, but this is an interesting chart. And it kind of shows you, again, I have to get out, either blow it up so I can see it or walk over. So here you can see the receptor that's there. So what's important, the big player in this, these rely on those dendritic cells. Wonderful surveillance cells in your skin, in your GI tract, in your liver. And basically they latch on to something and they become what we call an APC or antigen presenting cells. Remember, they gobble it up, and magically out they put out that little, oh, here's the bad guy. So they present what's going to become the determinant, the foreign piece that you're going to have to respond to. And so these dendritic cells activate, let's say this is the CD4, okay, and then it begins to clone itself. Some of them will become memory cells, but the vast majority will be activated helper T cells. Those are the effectors. That's the effector one. Effector because they're going to secrete, depending on what they encounter, a lot of powerful chemicals, activating other cells within the line, even other helper T cells. Over here on the other side, same deal. Except this is the CD8 cell. And there's usually here, schematically, they're using different antigen, different determinants on the proteins that are displaying. And then that will clone, and that now some of them will become memory cells, and that's great. So you get long-term memory. That's there. Okay, and the rest of them are effector cells that work differently than antibodies because it's more sort of face-to-face destruction. They're not gobbling them up and swallowing them after they've been neutralized. They're going to give them basically a lethal hug, sort of like that. Love that. It's like when shut up, Lou. Nobody cares. See, when I think of those, that's why I want you to remember those kinds of things. What is this idiot talking about a lethal hug? Okay. It's almost like Medusa-like. Remember her, snakes for hair? Should have washed her hair a little bit more. Perseus. Release the Kraken, that one. That's when the dog's been in the crate, we have to let him out. My wife and I go, all right, we're going to release the Kraken. You're up. Now, would the post office be open? Wouldn't be closed today, would it? My wife is asking me. I didn't think it's not a postal holiday yet. It's okay. She's got to stop. She's got to stop. T cells only process fragments displayed, and again, this is what I talked about previously. These MHC, major histocompatibility complexes. Without it, they don't get activated. And the way it works, class 1 MHC proteins, all cells display those except red blood cells, which don't have. Remember, effectively, the red blood cell is really not a cell. It's just a formed element whose whole job is carrying oxygen. That's when we talk about that in the respiratory unit, more so than anything else. Class 2s, okay, displayed by the APCs, dendritic cells, macrophages, and B cells. Okay, both types and bind to particular fragments, but it's the class 1s and the class 2s are different. The class 1s are relatively short. Okay, and typically those are endogenous antigens within the cell itself. They can either be self or non-self. Non-self, if the cell has been altered, read that as infected, or altered by bacteria, virus, changed cancers, or it's a foreign element, so to speak. Abnormal cell. They are the ones that activate the CD8s. Okay. Yeah. And so they basically, that the cell part the T cells recognize, they're informing the cytotoxic T cells that something bad is hiding inside. The class 2s, longer fragments that are basically extracellular antigens. It's a fine point, not a big one I'd ask you about. Okay. They are recognized by the helper T cells. So for our purposes, class 1 by the CD8s, soon to be cytotoxic. Class 2 by the helper T cells, CD4 cells, soon to be helper T cells. That's all. And they have nice little diagrams going over what this is, the difference between endogenous and exogenous. And I don't make much more of it than it is. So you can see this is a more complex system than just basically surveillance cells saying, oh, there's a foreign thing here, let's make antibodies. You got a cold, you got a stomach flu, whatever you want to call it. A little bit different. And so people went nuts over COVID, but it wasn't as it was a different process. That's why those monoclonal antibodies were effective. Don't get me started on the whole COVID thing, and let's vaccinate the world while we're here. All wear masks. So the CD4 cells that become helper T cells, one class only, so they're restricted. Same for the CD8s. Okay. And so it's all very, very specific. That's all they're talking about there. Not a big deal. So you can see I every time I read through this and try to look it up, it's not clear to me. And maybe I should try to do a better job. I'm not going to do it right now. But they're talking about this, how you can, the restriction, how to enable the CD8 cells to be activated by something that is not inherently in the cell to start. Okay. And dendritic cells apparently get around this by engulfing, because these cells have a relatively short lifespan and they break apart and just make more cells, and they get gobbling it up, as opposed to the traditional way. Let's say if there was a typical, like HIV was in the cell, you would be able to identify it that way, or tuberculosis. So I don't really understand it. And when I don't understand it that closely, I certainly wouldn't ask you about it. But I mean, there's effectively, it's a workaround, if you want to think of it that way, for some of these things that are a little bit different for nuances. T cells require not one step like B cells, but two. This is the idea of co-stimulation. This is kind of where the HIV is involved. That's part of it. It's really I think my understanding that it works on those CD4 cells, but involves the co-stimulating antigen. But I will take a look at that, because we do look at that a little bit, I would dare say, when we look at repro physiology, because we look at some of the diseases that are there. So you see both of those that are there. Okay. I'm buzzing through this for a reason, because I didn't think I have the time, but it's better to explain it this way. And I hope that this will play through the sound. Is that this thing? And I hope it works. I'm not guaranteeing. Ah. Trying to see if I heard something. Caramba, let me look down here. If it starts to get really noisy, let me know. I'll stop. Nada, huh? Let's get. I'll get it to play. I'm surprised it's not. Can't take it out. He won't be able to hear it. All right. I'll have to enable it some other way. That's fine. Let me go back. I apologize. See, I wanted to get, because that summarizes it pretty well, but I will read through it as best as I can and get that, and I'll get that animation to you in some way, shape, or form. Okay. These typical receptor, it's just an acronym. T cell receptor, doubly recognizing it by both the MHC, the major histocompatibility, whether it's a 1 or a 2, and the foreign antigen it displays. And that's really the triggering points that are there. And I mean, it's not the only factor, but that's the main thing. So what happens is To complete T cell activation requires the T cell to also bind to one of these co-stimulatory signals. Without that, it's an anergy, a system where it will either tolerate the antigen, it won't divide, it won't make any chemical agents in the form of cytokines. And that two-step process, again, is to avoid, because the immune system is so powerful, it will clobber anything in its wake. So T cells that are activated, then effectively they enlarge and they start to clone themselves. Okay. And notice it's not, that's what I was telling you about. It takes some time. The cellular system, when we look at why the TB test, when we start looking at immunological reactions, why it takes, before you get even tangible blood levels or a tangible response, it takes time to do that. Antibodies ramp up comparatively faster, as you will see. Now, notice, by and large, the T cells are gone in 7 to 30 days. But the difficulty there is when that's altered. And that's where those so-called regulatory cells play such a critical role. If they don't shut down, now you have this overactive system. In micro, did they talk about super antigens to you? Not ringing a bell? Super antigens are, it's like what causes necrotizing fasciitis, a flesh-eating disease. It's what caused scarlet fever. Okay, very, very severe, a toxic shock syndrome. Okay, or which is normally staphylococcal but can be streptococcal. They basically hyperactivate 20% of your helper T cells to go freaking wild and start pouring out cytokines so massive that usually the response is fatal if it's not caught soon enough. This is a system, it's effectively, again, it's so important to have a regulatory arm of the system that works appropriately. Activated T cells are a hazard because they produce large amounts of cytokines. Thank you for making my point. And this is one of the problems. That's why, and I don't mean to, a lot of people have been helped by these, what we call biologicals. These are these things you're seeing on TV. They're made with very similar with the techniques many of you have used in lab, being to identify these things, isolate them, electrophoresis them, PCR them, whatever. Okay, much more advanced than I could ever hope to explain it to you. And effectively, they are making these proteins and producing the appropriate agent for them to block them or to enhance them. So they show it to you a little bit in steps. I don't know how well, I mean, again, that's why I wanted to play the animation. I apologize. I think it would play. So dendritic cells engulf an exogenous antigen, process it, displays, in this case it's class 2. The double recognition, the CD4 cell recognizes the MHC complex and both the TCR and CD4 proteins. So it's binding twice. And then the animation is really good. So you need it where it would recognize and the co-stimulatory molecule. Boom. Now that's activated that, in this case, that CD4, which is going to become a helper T cell. And then they start to clone. So it's a pretty good explanation of what happens. That whole idea is, it's like the stupid two-factor identification I can't get away from anymore. Doesn't that bother you? I guess it doesn't bother you. Okay. Here they are. And so what happens, we get back over there, these are the cytokines. These are these powerful, extraordinarily powerful substances that cause havoc. Okay, all of the things, development, differentiation, responses, IL-1. IL is the parlance we use because we don't have to say interleukins all the time. Released by macrophages and stimulates T cells to release. And the big player here, make no mistake, is IL-2. The original treatment for a lot of things we did, cancers, a lot of immunological phenomena, was IL-2. We didn't know enough about it. That was really the first one that was synthesized because it would be useful to activate the system's response because effectively, and IL-2 to me is still the big player. IL-2 is the key growth factor acting on the same cells that release it, other T cells. So it activates the other T cells in the surrounding area. It's very significant. So they begin to divide more rapidly. Other cytokines are released. And again, as you can see, they address not just the adaptive response, but effectively encourage cells in the innate response, particularly that arm. You can't heal the skin magically, but you can put more cellular soldiers out there to address, because obviously we got a problem. Something got through the defenses. So something like this, we talked about interferons. Typically, interferons are more of an innate defense that hardens our cells if a virus is present. Remember, that cell will release certain interferons that'll tell other cells, we got a virus in the neighborhood. Let's tighten up. We don't want any problems. Versus, here's gamma interferon that makes your macrophages more powerful. So I hope you're beginning to imagine just what this is like if this gets out of control. If you've ever seen anyone with a full flare, you don't want to. And so this is you're not going to have to memorize the chart, but let me give you some idea. So these are more of your NK cells, natural killer cells. They're basically mostly T cells that are out there that we find, and they're part of our adaptive immune system. They're the ones with not the gamma interferon, but mostly the alpha and beta interferon. The gamma activates macrophages, expression of more 1 and 2 MHC proteins, promote more differentiation of helper T cells. Here are the interleukins. So once a macrophage is activated, it promotes inflammation, more T cells. It's a pyrogen. Not every infection or invasion causes a fever. This one does. Resets the thermostat of the hypothalamus. It's desirable. As long as it's limited, fevers are good. Remember, temperature is a good thing. You increase your body's production rate. You increase reaction rates. All of those type of things up to a point. Big trouble. The big player, IL-2, secreted by the helper T cell, stimulates T and B proliferation, regulatory cell development, NK cell activities. And those regulatory cells are so important because they're the shutdown cells. And again, when that line is altered, effectively, that's the tragedy of HIV. And so that once your immune system collapses, most people just die of infections that normally we would never get. And that's really how it was first defined. They got a kind of fungal pneumonia, which is extraordinarily rare, other than very, very sick individuals. And there was a cluster of those in San Francisco, which had the largest per capita men's gay population, and they were basically associated with immunological deficit. And the doctor did some tests and published it in '81. He said, we were seeing that in Philly, which was nationally the second highest proportion of gay men. I told you, I'm having lunch with these guys. Did I tell you my wife's downstairs neighbor, that anecdote? No? You remember these. I didn't? Oh. I had a lot of fun. They were interesting people. Good people. But I remember, don't take it the wrong way. I hope it doesn't offend people. But these men, couldn't come out, but some couldn't avoid it. And they had girls' names, which is very popular. The late Freddie Mercury, they called him Melina. There's a famous Greek actress called Melina Mercury. They all had different girls' names. And I forget what this guy's name was, Brandy, for his girls. And I'm sitting there having lunch. We're at his around his kitchen table in his apartment. It's a downstairs apartment from my first wife and I. And and this guy left. You could see, could hardly interact. Very, very. You could see illness was there. Very, very spindly. Almost looked in pain. And I walked out. I said, "What's wrong with him?" She goes, "She's got it. The it was AIDS." Little we know. I mean, it was very interesting. Now that this was 50, almost exactly 51 years ago. So IL-4, some helper T cells promotes differentiation. IL-5, some they have some attacks. See what's going on. I'm getting to the biggies. IL-10, secreted by macrophages, helper T and regulators inhibit, turn down the cellular immune response. This is an immunosuppressant. So using that, okay. So a lot of times we want something that will mimic IL-10. That's when you see these biologicals. And we're not done with the list. I've got a bigger list in this. I'll show you in a second. Okay, IL-17. This is an extraordinarily important item. Inflammation in many autoimmune diseases. What Humira is, what Cosentyx is, which I took first, is an IL-17 blocker. You see it advertised all the time. And what it does, it basically, it gets out of control. I mean, it just hypes up your immune system like crazy. Whereas what I took afterwards, the Humira, was a tumor necrosis factor. Okay, and so it was anti this. And again, this promotes inflammation. It's great to get rid of tumors, but fortunately, okay, if you block it, you have a greater propensity to have tumors. It's this. You're balancing a system that's either going to make you very ill or very much better. And you're trying to keep them in alignment like that. So I took one to bolster my immune system. Where? Now I have to take one to suppress it, hard to tolerate. Not easy. So that's the complexity of this system. I will get it so we can do the animation. We'll go over to the lab and talk heart, etc., etc. Let me get us out of this. And if somebody would go over and get those Scantrons on that little desk in front of my door, well, I would appreciate it. Please. For those of you who aren't awake, I hope you had a good. If you're awake and have a good time.